Yesterday, I gave a lecture, which is an advanced lecture, about how can we go from imaging to genetics. Today, it's back to basic. But in fact, it's a daily life. And because you know these basic imaging tools, it will help to get very nice and precise diagnosis. So my talk is divided in 3 parts. I will first take a time to speak about ventricular measurements, and we'll move to midline. You know the cavum septum pellicity, and we'll speak about the anterior complex and the interest to have a look at this anterior complex. And we'll move to the surface of the brain to have a look at the Sylvian fissure, which is for me a very important landmark to have a good view of the gyration and the maturation of the brain. So to begin with, ventricular measurements. You know that one major item in the guidelines of ISUOG is to look at the lateral ventricles. Why? Because ventriculomegaly is the main finding of our CNS pathologies. But in fact, how should these measurements be performed? We have the reference method described by Cardoza a long time ago. The image been obtained in axial plane through thalamic nuclei at the posterior margin on the choroid plexus. But 2 years after, Elzerman underlines that this method gives false positive due to off-axis images plane, angle measurements, improper choice of ventricular boundary. So, in fact, indeed, in the main practical issue in routine practice is when you are facing borderline ventriculomegaly, is to establish whether this ventriculomegaly exists or not. Why? Because these patients were referred in our lab for borderline ventriculomegaly. And you see, we have 10.8 and 12, but if you scan it properly with accurate measurements, it was in fact 9.2. There is no ventriculomegaly at all. And I will say that 1/3 of the ventriculomegaly referred in our lab for mild ventriculomegaly or minor ventriculomegaly are false positive ventriculomegaly. It's as when you cut a slice of zucchini. If you are orthogonal to the zucchini, you get this slice. And if you are off-axial, you get this second slide, and you see that the caliber of the first one is less than the second one. So, because of that, we publish in 2009 imaging scoring method using 5 criteria. And we'll go on this criteria. We have primary criteria, and the first one is to have a strict axial plane. What means a strict axial plane? The midline should be perpendicular to the ultrasound beam, and the midline structure should be equidistant from the proximal and distal calaveral margins. What I mean, you see that the midline is perpendicular to the ultrasound beam and equidistant to the 2 volts. So we have the answer, how should we cut, in fact, the brain? But at which level should we cut it? In that case, you should have adequate anatomical level. You should have 2 landmarks, one anterior, which can be cavum septum pellicity or fornix colon, and one posterior landmark, which is the fluid-filled triangular V shape of the ambient cisterna. This is the anterior landmark, and this is the posterior one. You see that you have CSF here between the 2 internal borders of the occipital hemisphere, or lobe, sorry, and this is, in fact, what we call ambient cisterna. And it's a V shape. If you are not strict axial, the V will disappear. And it's much more accurate than the thalami. Now, location of the atrium. Measurements should be performed at the level of the atrium. But where is the atrium? In fact, Cardoza said we should use the glomus of the plexus choroid. For sure, it's easy to identify I remind you, this paper was published in 1988, so at that time it was nice to have a good landmark, very echogenic, but it's not reliable, in fact, because the location of the glomus may change depending on the shape of the plexus and also on the degree of dilatation. And neuroanatomy suggests a more reliable landmark, which is the internal parieto-occipital fissure. This fissure is located opposite to the convergence of the parietal and occipital horns, and it's the exact definition of the atrium. It's depicted on the inner border of the hemisphere as early as 20 weeks as a small depression, and it becomes deeper in the third trimester. And I will show this at 20. You saw this small depression, and after it becomes deeper here at 28, and deeper in 32. So you can see here small depression. So it's very easy to find this landmark. If you look at this case, which was referred in our lab for ventricular megaly, and you see here there is dilatation of occipital horn. It's not the good way of measuring it. You see that you are not orthogonal. You don't have the same distance from the midline from the proximal and distal cavalier margins. And if you measure, in fact, properly, this patient have no ventricular megaly at all. How to place the calipers? The calipers should be on to on, so you don't take the wall, it's on to on, and it should be orthogonal to the wall of the ventricle and not orthogonal to the midline, but orthogonal to the wall, on to on. And you should have adequate image size. You should avoid excessive or low magnification. The main interest of this method is to improve the reliability of ventricular measurements, especially when it's close to 10 millimeters, and improve also reliability of the follow-up, especially if serial examinations are performed by different operators. Let's move to the anterior complex. You know that cavum septum pellucidity is a very important item to be sure of the integrity of the midline. It's easy to identify, for sure. It should always be evaluated between 19 and 37 weeks, and it's altered in many pathologies involving the midline, holoprosencephaly, agenesis of the corpus callosum in complete form, and absence of the cavum septum pellucidity is also encountered in severe ventriculomegaly, schizencephaly, and congenital agenesis of the corpus callosum, sometimes related to septo-optic dysplasia. But in our casuistic, we have case of false image of cavum septum pellucidity. Like in this case, this patient was referred for ventriculomegaly, and cavum septum pellucidity was described as normal. But what you see here, it's not the cavum septum pellucidity. In fact, it's dilatation and displacement of the third ventricle. If you compare to a normal case, and this patient, this is the sagittal view, have a complete agenesis of the corpus callosum. Because of that, in 2013, we published this article how to improve detection of the midline cerebral anomalies, and you have to move from cavum septum pellucidity to the anterior complex. This is the anterior complex, magnification, and just to explain what is the anterior complex, this is the cavum septum pellucidity in axial and sagittal view, and if you have a look here on the two borders, you have the frontal horns. It's very interesting to have a look at the frontal horns just to be sure that they are symmetrical. If this one is larger than this one, you may deal with ventriculomegaly unilateral on the proximal hemisphere, which is more complex to measure. So this is interesting to have as an information. If you look here, you have the genu of the corpus callosum, which is here, and here you have a sulcus, which is the periclosal sulcus, and this sulcus is here. You see, it's like an anchor. the basis of the anchor is here, and the handle here is the interhemispheric fissure. So here, periclosal sulcus here, and here, the interhemispheric fissure. Is it worthwhile to have a look at the interhemispheric fissure? Yes, in some case, you don't have any interhemispheric fissure, like in holoprosencephaly, but we've published a paper in 2013 about distortion of the anterior part of the interhemispheric fissure. And in fact, it's interesting to have a good view of the midline when you have this kind of images. And you have also CNS disorganization. And we have recently seen 3 cases of tubulopathy with other findings, but the 3 cases have also this distortion of the interhemispheric fissure. For midline analysis, so you should look at this anterior complex. And just to finish, we should move to the surface of the brain to have a look at the Sylvian fissure. You know that the Sylvian fissure is not cited in the ISUOG guidelines, but if you look at this drawing here, you see that the Sylvian fissure is here. So you have the Sylvian fissure under your eye, so it can be useful to have a look at the Sylvian fissure. But how to look at the Sylvian fissure, it's a really important thing to discuss. In fact, you have to be aware that the shape of the Sylvian fissure will change over time. And if you have an axial view at the level of the fornix column here, which is a very precise anterior landmark, and here you have the V shape of the ambient cisterna. Now, look at the posterior margin. This one, this is the insula, this is the temporal lobe. You are at 22, and look here, here, here. I come back to here, here, here. So you have an angle of 45 degrees here at 22. It will be square at 24. And then you know that at 32, the temporal lobe will be in the middle. Half the way will be at 28, and a quarter of the way will be at 26. And between 26 and 28, there is something which appears, which is the superior temporal sulcus. So with this, in fact, you have a precision of 10 days when you don't know. Oh, sorry. Here, sorry. So this is this one. It's okay. Sorry for that. It's okay. Oh, okay. So here you see the insula here. Here 25 degrees square between insula and temporal lobe, and then at 32 in the middle. Oh, sorry. All the way from here to here at 28, a quarter of the way at 26, and between 26 and 28, look at the temporal sulcus, the superior temporal sulcus. And we have at around 30 weeks, the inferior temporal sulcus, which appear here. So with that, you have a very easy tool to have a good idea of the maturation of the brain. Don't look at the Sylvian fissure in all plane, but look at it very carefully with this landmark, anterior and posterior, and if you do that, you'll be sure that it's very simple to do. And this is the article we made with Guarello, so you will find this on internet about the way of doing that. And I just have this case, a quick case. Patients, I saw these patients late because of denied pregnancy. I did my biometry, and look at the biometry. Are we at 28 with a small one set of IUGR, or at 26 with a big head? It's a question. So you just have a look at the Sylvian fissure. You have the insula, which is here. You don't see any temporal sulci. And here, it's 32, 28, 26. So what do you think? 26. Okay. In that case, you should have a look at the TCD. If it's 26, 28, it's around 31, 32. If it's 26, it will be 28 or 29. So you have a look at the TCD. It's 28, so it's fit with 26. And as I told you yesterday, when you are 26, you begin to see the central sulcus here. So with all this information, you know that this patient is around 26. Now, look at these patients. These patients were referred at 27 weeks for isolated ventriculomegaly. I did a paper, an editorial in the White Journal, how to handle this kind of isolated ventriculomegaly to be sure it's isolated. You put your probe, so you have to look at the Sylvian fissure. You are 27. What do you think? You see, it's completely abnormal because the insula should be here, but look here, it's very smooth. And in that case, you have almost, or it's most likely, a diffuse cortical anomaly. And you did an MR, and you see this undulated pattern, which is suggestive of a diffuse polymicrogyria. So you see the interest of the Sylvian fissure. So don't look at the Sylvian fissure in all planes. Do it in one plane, but you know how to do it. And to conclude, I show you the importance of using precise neuroanatomic landmarks for sonographic examination of fetal brain. It's useful for beginners, but also for experts. And it's useful also to test new ultrasound system because you know what you want to see. If you want to see the Sylvian fissure, you can test your machine with the Sylvian fissure or with the margins of the ventriculomegaly. So for me, it's really important in the daily life. Thank you. Okay. You see the V shape of the ambient cisterna here, which is here. You see the fornix column. You have the insula here. This is the temporal lobe, and there is a small depression here. So what do you think about, don't look at this. So, okay, you see, the insula will be at 32 here. It's out the way, and you have the small depression of the superior temporal sulcus. So it's correct to think that this patient is around 28. So in that case, if you can move, if you move to the TCD, what you want? You want me to change the probe? No? Okay. Okay. Difficult to see the border here. Up. So you are expecting 32, 31, 32. So you all agree that this patient is around 28, which is what we are just seeing. So you see that here, the two landmarks which are very important is the interior. The anterior can be the cavum septum pellucidum, which is here, but just below, you have here the fornix column. And in fact, it's much, you see the cavum septum pellucidum, you can see the cavum in many images, but in fact, the fornix column, it's more precise because you see here you have the fornix column, okay? And you see one thing, in this patient, you have a ballonization of the occipital horn. So it's very common to have this ballonization. So if you take here your measurement from here, sorry, this set, I will do it not in the proper way here. And in fact, if I do it, you see this one, you have here the internal occipital sulcus, and if I put orthogonal, you see it's 6. You see there is more than 2 millimeters of difference between measuring in the occipital horn and at the proper level. So, so this is very important. So just to remind you that when I have a look at the Sylvian Fisher, what I want to see, it's the fornix column here. Now, if I look at the anterior complex, you can see the anterior complex at either on an axial view or a corneal view, as you see here. Sometimes it's a little bit difficult to see the periclosal sulcus, but you can see here the genu or the fibers of the corpus callosum here. The two horns, frontal horns, which are symmetrical in that case, the cavum septum pellicidi. Sometimes the cavum septum pellicidi is very thin, sometimes it's echogenic, sometimes it's barely visible, but you have to see a clear line separating the two horns. You do not have to have a communication, a free communication between the two horns. If there is free communication, you are dealing with a destruction of the cavum septum pellicidi or a congenital absence of the cavum septum pellicidi. If it's destruction, you have to look for schizencephaly or ventriculomegaly, very severe and obstructive ventriculomegaly, which will destroy the leaves of the septum. And if it's congenital, you may have a square horn here, which are encountered in case of steptoptic dysplasia. And in some cases, you have also heterotopia, subependable heterotopia. So let's go here. So you have a normal anterior complex. Okay. We'll move. We discussed yesterday about the third ventricle. You see it's clearly visible here. And you see how nice you can see the aqueduct from the third ventricle to the fourth ventricle. You see? You see there is the lumen up here. So you see the two borders of the aqueduct and the lumen between the fourth ventricle and the third ventricle. You see, when you have an isolated ventriculomegaly with a third ventricle which looks a little bit dilated, you should have a look at this aqueduct, and it can be easily seen. Yesterday, I showed you a case of Joubert syndrome, and I tell you that in Joubert syndrome, the AP diameter is, in fact, larger than the transverse diameter. Normally, the transverse diameter is larger than the AP diameter. When this diameter is large, like this, it's because you have elongation of the peduncle, and in that case, you are dealing with Joubert syndrome, and you should have a very should look at the kinase to see if they are not echogenic, and in that case, you have very nice kinase, and also a very you look at the end just to see if there is post-axial exadactyly, and in that case, you see there is no post-axial exadactyly. You have to do that in both hands and both feet. Okay? So let's go back, because some people think that I do only CNS. No, I do also whole body scan. Maybe you can appreciate here how clear are the images on the brainstem, on the two peduncles, and you can see here the aqueduct in axial plane. Is there any question from the audience about axial plane before moving to other plane?
Questions? Okay.
No question at all?
Yeah, it's coming.
Sometimes there are questions.
Hello.
About, yes?
Sometimes when you read in the papers, you see the term septal leaflets, and it's related to the cavum septum pellucidum. Could you point those out clearly, please, in
Yes.
the axial plane?
In fact, here, you see, it's the border of the cavum septum pellucidum. This is the border. And there are, in some case, when there is here, in severe obstructive ventriculomegaly, the leaflets are destroyed, and there is communication, and it can be on one side, on the other side, or complete or incomplete, depending if it's long-term ventriculomegaly or short-term ventriculomegaly. Okay. No question about the optic nerve. I know people want to see the optic nerve. In that case, you see clearly the two optic nerves here. You see, depending on how important are the peripheral spaces. In that case, it's very easy to see the optic nerve coming from the chiasma, which is here, and the two optic nerves here. Okay? Perfect. She's a nice patient. Yeah. Keep in mind this V shape. Yeah? Try to have always this V shape. And I don't underline that you see when I scan, you see that I can do the same kind of images that I can do with MR. You see? So for me, doing fusions, I show you some images of fusions yesterday. It's very easy because you see, when I fuse, I took my images in MR and I put this on my ultrasound system, and I have almost the same images. You see the temporal lobe here, you see some subarachnoid vein here, you see the foliation of the two hemispheres, you see the fourth ventricle, the brainstem, and you can go from top to down like that. Okay? Here I just show you the central sulcus. I show you that at 22 there is a small depression, and this depression becomes deeper and almost at the middle of the hemispheres at 28. So it confirms the fact that we are at 28. Okay? Let's move to the sagittal view, if we can. Yesterday it was difficult. I will see if today it's better. Sorry. I don't want to press too hard. Yes, could you just... Oh, sorry. You know that I tried to do my best, but okay. It's not perfect, but you may see the corpus callosum here, from here to here, but you want to see the entire part, and I agree with you that I want to see the entire part. So next time up. Just to tell you that if I can do that, we can do on a corneal view to see, in fact, the corpus callosum from anterior to posterior. But when you do that, in fact, you see the fibers of the corpus callosum here, but you have no idea of the length. So you may have short corpus callosum, and you do your work like that, and in fact, you may have small corpus callosum, and to have a clear view of the corpus callosum, you have to get the sagittal view. Sorry. Here. Sorry, it's not completely clear, but you measure from here to here. And I have a question for you. If the corpus callosum is short, what are you doing with your image? Not with your biological workup. What the main things to do, and you have a look at something very important in case of short corpus callosum, which is something which is very close to the corpus callosum. You know?
The idea?
You see this sulcus here. We discuss about this sulcus. Which is the sulcus? The Periclosal Sulcus, yes. And you may see here sulci, which is the sulcus, which is the marginal sulcus. You should have a look at this sulcus. If this sulcus looks thick or bright, what are you looking at? To lipoma. Yes, a periclosal lipoma. So in that case, if there is a shortness of the corpus callosum, look at your sulcus. If your sulcus looks too bright and enlarged, it may be a lipoma. And if you wait till the end of the pregnancy, you will see that this structure will be thicker because lipoma have a tendency to grow over time during the pregnancy. Here you have a nice view of the vermis, and because of that, you are sure that you are in the midline, because you have the vermis, which is more echogenic than the two hemispheres, and you have also the nasal bone, and you see all your corpus callosum from the genu, and you have also here the rostrum, genu, body, and splenium. So it's, in that case, a good midline image. Okay? Other question from the audience? If you feel free to ask, even if it's very simple. I think there is a... Okay. If I have ventriculomegaly, what should I do? So I have a ventriculomegaly at 12 or 13. It's not the case here, but how do you do your workup? If there is a ventriculomegaly, it can be an obstructive ventriculomegaly. So what's important in the case is to know the biometry, the specific biometry. If it's decreased, the chance to have obstructive ventriculomegaly is less than of the classic events with, in fact, atrophy of the brain. So it should be increased. You should have a look also at the cavum septum pellicidi to see if there is some insult on the leaflets of the cavum septum pellicidi because of barotraumatic insult. And also look at the pericerebral spaces. Here you see clearly the pericerebral spaces which disappeared when there is obstructive ventriculomegaly. There is a question?
Yep.
Okay. Okay.
Prof, just could you show us the optic chiasma and if you measure it?
Sorry?
The optic chiasma.
The optic chiasma. How I measure the optic chiasma? In fact, it's very difficult to measure. I'm almost sure that I see the optic nerve. If you want me, if you ask me really to measure it, in fact, I measure the nerve from here to here. In the real life, I've never measured the optic nerve on ultrasound. I do an MR, and I never measure. It's a subjective approach, because to have a reliable normogram of the optic nerve calibers is very difficult, because if you ask two physicians to measure the optic nerve, there is almost a very poor inter-observer agreement. So for me, I can say, yes, there is optic nerve, they look symmetrical here, but I prefer to have also confirmation with my MR, and I do most often only subjective analysis. Even if Jean-Philippe Beau do a very great job with 3D and try to give more precise measurements with the normogram that he has established.